Good afternoon, everyone. I'm Patrick Knoll. I'm Vice President of Finance and Management here at the Home Care Association of New York. I'm glad that you can join us for our 2022 Medicaid Home Care Cost Report session conducted by Michael Simione from SimiTree. This is the fourth year of the new Medicaid cost report. I don't know if we can call it new anymore, but what I can tell you is that for licensed home care service agencies, CHAs, and fiscal intermediaries, completing it the first couple of years have been very challenging. Last year was a little better, but this session here is to help you all do the best you can. It was issued on June 1st of this year, the 2022 Medicaid cost report. There's a due date of August, so we wanted to be able to help all of you do the best you can in completing that. So with that, we'll turn it over to Michael, who has a ton of experience working not only with the Medicaid cost report, but the Medicare as well for our certified agencies. And I've heard many sessions with Michael, and it should be terrific. So thanks, Michael.
Thank you, Pat. As Pat mentioned, my name is Mike Simione. I'm a director on the financial consulting team at SimiTree. My area of expertise is cost reporting. And as Pat mentioned, mainly Medicare cost reporting for certified home health agencies. But in the last 4 years, we've been very involved and grown our expertise and services in the New York Medicaid home care cost statement for CHAs, LICSAs, and FIs. I've been in the home care arena and worked for SimiTree for the past 12 years. My background's in data analytics and finance. So today, what we're going to talk about is the updates. We're going to really focus a lot of time on the updates this year because, in my opinion, there were some very good updates made to this Medicaid cost report. And then we're going to highlight, best practices and recommendations that we make, as we prepare cost reports, but for your own agency, if you're preparing them or if you're working with another vendor to help you in preparing those cost reports. So as I mentioned, we'll go through those key schedules, what's on each schedule from a high level, and then really focus on schedules 3, 4, and 5. Those are the key schedules, and those are the ones where they had the most significant updates. And most of these updates, in my opinion, are very positive. They heard your feedback. They listened to the feedback that providers in New York State gave on the cost report, and they made changes at least to those 3 schedules. And I think it'll help and assist agencies in completing the cost reports. Then a big component that we're going to go over, and what we see most agencies and preparers struggle with, is the various allocation methodologies that can be utilized and how to complete those. We'll briefly touch on the different labor and compensation schedules. Like I said, we're going to focus on 3, 4, and 5 today, but we will touch on those. And then we'll talk about surviving the audit process. And when I mean surviving the audit process, it's everything you do before you get to the audit process. So that's work paper preparation and maintenance, and then making sure you're timely filing of that cost report, which, as Pat mentioned, is due specifically August 30th of this year. So wanted to start with an overview of the schedule. So this gives a good breakdown of the schedules. And, if you're unfamiliar with the home care cost report and you're new to this, I apologize. Welcome. It's going to be a very, fun experience, first experience going through these. But for those of you that have experienced, this is kind of, general information that you should already know. But just to break it down, Schedules 1 and 2 are just general agency and entity information that you're reporting. So you're going to list, your NPI number, tax ID, your provider number, your address, the counties that you service, etc. That's what goes on schedules 1 and 2. And then once you complete those schedules and you submit them, it opens up every other schedule. So when you see 3A, 3B, 3C, what that means is there's different schedules. A is for the certified home health agencies, the CHAs. B's are for the LICSAs, the licensed home care service agencies, and then C is for the FIs, the fiscal intermediaries. So when you're looking at these, you're looking at, on schedules 3, total cost and expenses for your agency. On schedules 4, your general service cost centers, that's your general and administrative and general, all your overhead costs. On schedules 5, you're looking at your service statistics, and we'll go, like I said, into detail into those 3. They're bolded and they have the most significant changes. Schedule 6 is only for FIs and has their tier statistics. Schedule 7 has your current charge to the general public. 8, compensation analysis for employees, and 9, compensation analysis for contracted employees. Schedules 10 are your worker recruitment and retention information. So your statistics about worker recruitment and retention. So how many staff did you hire? Did you retain? And did left your organization, or did you terminate throughout the year? 11 and 12 are your labor cost and labor utilization, using those to calculate on Schedule 13 your average compensation. Schedule 14 is another statistical schedule. It represents all the live-in services that you may provide under any of these programs. Then we have our salaried labor costs on Schedule 15, our top 10 highest paid administrative officials on Schedule 16. And lastly, our balance sheet and income statements are reported in the financial statements on Schedules 17, 18, and 19. So that's a general overview of the different schedules. Like I said, we'll focus today on 3, 4, and 5. But it's important to know what's on all of these schedules. So, this is just general information. We group the schedules based on the general information that's included. So starting with your general information, as I said on schedules 1 and 2, that's just agency and entity information. Financial data, detailed financial data, I should say, is reported on schedules 3 and 4. That's your total income and, total expenses, as well as your A&G expenses broken out with a bit more detail than may appear on your financial statements. Then you've got your statistical data, which are reported on schedules 5, 6, and 14. Your general charges, or your charges to the general public, are on Schedule 7. The labor compensation schedules, there's a lot of them, 8, 9, 11, 12, 13, and 15, as well as your top 10 highest paid admin officials on 16. And then lastly, your summarized financial, your whole entity financial statements on 17, 18, and 19. So this groups the schedules based on the information that's included, and some of your source documentation can overlap across these schedules. And that's why we wanted to show it this way rather than this way, just showing each individual schedule. So we're going to start with Schedule 3. If you're unaware of Schedule 3, a quick overview is there's dedicated schedules, as I mentioned, for each of them, a 3A, a 3B, a 3C for the CHA, LICSA, and FI respectively. And they're geared towards your entity's total expenses. So Schedule 3 is going to be representative of both your administrative and overhead expenses, as well as your direct care expenses. And important here is it includes non-reimbursable services. And we'll talk about non-reimbursable services. That's the biggest change we saw in this cost report. And I think it's a great change that DOH and KPMG made to the portal and the reporting of this year of breaking out non-reimbursable, where they previously referred to them as non-allowable expenses. The key when you're reporting on these schedules is making sure you're putting your expenses on the appropriate line and appropriate columns and allocating appropriately. And we'll talk about allocation methodologies and work papers and crosswalks and everything a little bit later. But when you're looking at this, where you want to start with is your trial balance and or your P&L income statement for this. So that's the supporting document on Schedule 3. The total expenses on Schedule 3 should reconcile to these financial statements, either your trial balance, P&L, or income statement, less any reconciling items, bad debt, out-of-state costs, or non-reimbursable services. And it's important that we have crosswalks, and I'll show you what I mean in a little bit, what I mean by a crosswalk from the supporting documentation, indicating where everything belongs from the source document, your trial balance, P&L, or income statement, to the specific cost report schedule. It does include your program administration expenses, and those values must tie over to Schedule 4. So this is what Schedule 3, the header, looks like on Schedule 3. So in column 1, you're looking at total entity costs. And the one thing that I'm still not a fan of, and I don't agree with, and I don't know why they changed, this schedule flows from left to right versus right to left. So you have to look at everything kind of going from 11 down to 1 rather than 1 up to 11. So that's why we see total entity costs all the way on the left on 1, and that's going to be a total. So I'm going to start on the right and go right to left. So we break down the cost on Schedule 3 for your entity into different categories. And those categories are all other, your contract services, your transportation, your staff training, your RN supervision and assessment, which is strictly for RNs. So anything that's RN that's the only cost that can be recorded there. Your program aid and direct care, so that's your main primary direct care expenses. It's going to include salaries and benefits, everything that's not contracted or transportation or training. And then you've got your program admin, that's your overhead costs, and those are going to flow over from Schedule 4 into this column 5. Then we have a subtotal in column 4, and that subtotal is the total reimbursable services. And it's a sum of columns 5 through 11. As I mentioned, this goes right to left, a little counterintuitive. One of the things that I've been recommending they change, but the other changes they made, I would say, are good. This is the one change I would recommend they make going forward. Then they have 2 columns now beyond that subtotal of total reimbursable that represent non-reimbursable. The first non-reimbursable cost is your worker recruitment and retention costs. And then the second non-reimbursable cost is any other non-reimbursable services. So if you're looking at a certified home health agency, the non-reimbursable services would be personal care services. If you're looking at Alexa or an FI, those non-reimbursable services could be NHTD or TBI program services. And then everything adds up together. So you got your subtotal in 4 plus your totals in 3 and 2 add up in column 1. And your total expenses in column 1, that's what's going to tie back to your financial statements, your income statement, your trial balance, that source document you're using to populate this. So in this, what changes happened on Schedule 3? So we're looking at the addition of these non-reimbursable service types. So most of the cost reports in prior years, the reason for this change was they included non-reimbursable service expenses within the reimbursable service lines. Meaning for LICSAs, they were including NHTD and TBI expenses on the personal care, shared aid, live-in, whatever service lines there are for the LICSA. So now there is a specific location to report all non-reimbursable service expenses. And they want you to clearly identify and separate your total reimbursable service expenses versus your non-reimbursable service expenses. So when you look at it, you have to think about what's included in each program by New York State. So when you're looking at this, when you're looking at, like I said, certified home health agencies, that includes reimbursement for all of the skilled care under the home health benefit, right? So that includes nursing services, therapy services, home health aid services, medical social worker services, and maybe some other services depending on the payers and contracts that you have. However, personal care services, private duty, home and community-based services are not reimbursable under the certified home health program. And so those would be non-reimbursable services. So we always think of it when we're preparing Medicare in the same way. Our reimbursable services are our RN, LPN, PT, PTA, et cetera costs. And then if the agency is also providing private duty services, home and community-based services, those would be non-reimbursable. If you're looking at Alexa, the LICSA program reimburses for personal care level 1, personal care level 2, live-in, shared aid, nursing supervision, and assessment. It does not include, the LICSA program is separate from the NHTD, the nursing home transition and diversion program, or the TBI, the traumatic brain injury program. Those are separate programs. So those would be considered non-reimbursable services under this home care cost report. So that's the why they separated these out and they listed these non-reimbursable services, and it's clearly structured, as you'll see in a moment, on the cost report. In addition, they wanted to break out the worker retention and recruitment costs. And I'll talk more about, the resources available on the DOH and KPMG portal that can help you with calculating your worker retention and recruitment costs. But they've found that historically, most agencies misreported the worker retention and recruitment costs on Schedule 3. So they wanted to create a specific location to report these non-reimbursable worker recruitment and retention costs covered by, I'm going to refer to as WR&R. It's just going to be easier for me. I apologize. That costs that are covered by the WR&R revenue. So in addition to that, you also need to make sure you're including all of your other non-reimbursable, and this is what we would call non-allowable in the Medicare world, but they're lumping non-reimbursable and non-allowable together. That include, aid meals, charitable contributions, bad debt. All of that should be in column 2 with the other non-reimbursable services, not with the worker WR&R costs. So column 3 is strictly for the WR&R costs. So what does it look like for a CHA? So previously it was all direct care and they listed all the services, including they had PC services and shared aid services on the CHA cost report included in direct care. Now you can clearly see we've separated. The top portion shows HH, home health aid, physical therapy, OT, RN, MSW, nutrition, etc. All of those that may be covered by your certified home health agency contracts, including nursing supervision or nursing assessment if it's covered. And then there's a subtotal of those reimbursable services followed by other non-reimbursable services and personal care services. So that other non-reimbursable services can include anything that's not included under the home health benefit, the home health program, including those personal care services, which would be reported on their own line, and then grand totaling that subtotal with the non-reimbursable on line 20. So I think this is a great change to the cost report because it's making a little bit clearer what they want included, what they're trying to look for and assess when they're auditing and looking at these. They're looking at strictly the CHA services, strictly the LICSA services, and strictly the FI services. So as I mentioned, those non-reimbursable services are those personal care services. And basically, CHAs are not reimbursed for the LICSA services directly. And so they replaced those LICSA services lines with those non-reimbursable personal care services all lumped together. And so lastly, in the column here, we go all the way back for column 7 for RN supervision and assessment. When you go into the cost report, you'll see that most of that column is grayed out except for the nursing expenses. So you can only put your home health aid RN expenses there, your nursing assessment and nursing supervision. Those are the only rows where you can enter data. So not only did they enhance it by kind of categorizing, sorting, and like eliminating some lines and making it a bit clearer, they also grayed out cells where you cannot put information. So nursing assessment and supervision would strictly be services performed by an RN. And so you could only put it on the 3 lines, the line here for HHA nursing on line 4, or lines 15 or 16 for nursing supervision or nursing assessment. Next up, we'll go through the LICSA and you'll see it's very similar. The LICSA program covers these top services only. So PC level 1, PC level 2, PC level 2 hard to serve, live in, nursing supervision, nursing assessment, shared aid level 1 and shared aid level 2. So those are covered under the LICSA program. Everything else is not covered. So that includes other non-reimbursable services. This other non-reimbursable services line will include both your NHTD and TBI program expenses. Subcontractor services. That is, if your employees are being subcontracted to provide services at another agency, you're still reflecting and incurring the expense for those subcontracted services that are supplied to another entity, but they are not reimbursable under your LICSA because you're not being reimbursed for those services, right? You're contracting your employees out to another entity to provide those services. So those would go under this non-reimbursable. In addition, they got feedback from providers, and some providers, LICSA providers, are providing home health aid services. Those home health aid services that if they're not falling into the category and being reimbursed as any of the LICSA services, those would also fall into this on line 12. So once again, a subtotal of just the reimbursable. These are just what you're reimbursed for under the LICSA program benefit. And then grand total reflecting, including all of those non-reimbursable services, subcontractor services as well. So as I mentioned, the reimbursable services are personal care, shared aid, live-in, and RN supervision and assessment. And so, subcontractor and home health aid service lines were added. So those non-allowable include those NHTD and TBI. Pretty sure I've said all this. Subcontractor services are to be reported on their own line in the direct care column. And then non-reimbursable services are to be reported on their own line in the non-reimbursable services columns. And as I mentioned, LICSAs can provide HHA services even if they're not subcontracted by the CHA. So that's one thing that DOH and KPMG learned from feedback from providers. So they included the ability to reflect that on the cost report. And lastly, for FIs, And so FIs, they never had a non-reimbursable or a non-allowable services line, but now they do, which is great. So when we're looking at your FI, you're looking at your CDPOS services. So for individuals, that basic hard to serve or live in level of care. And then for multiples, your basic hard to serve and live in. And then you have your other non-reimbursable. And I think they learned this year, one of the things that they said is they FIs can and do provide NHTD services. And so those would be included in this line. So they added it. They had something for CHAs and LICSAs previously, but it wasn't very specific. It wasn't very detailed. It wasn't very clear. So they're trying to make things a little bit more clear where there's specific designated locations, lines and columns for specific costs on these cost reports. So, same thing, the reimbursable services, the individual versus the multiples and the different levels of care. And then, FIs do have non-reimbursable services, for example, the NHTD. And there was no place previously for these services to be provided or to have their cost detailed on the cost report. So next, we're going to go from schedules 3 to schedule 4. Schedule 3 is probably the most challenging. Schedule 4, probably the second most challenging, but they made schedule 4, once again, good updates and made it a lot cleaner and easier to work with. Once again, on schedule 4, we still have those dedicated schedules, 4A, 4B, and 4C for the CHA, LICSA, and FI. And then we have, they're geared towards including or detailing your administrative, your overhead expenses for your agencies, for your entities. So making sure, once again, that we're recording these expenses under the appropriate lines and columns. And when you see the schedules, it combines, the tables that I showed earlier. The supporting documentation for this will once again be your trial balance and or your profit and loss or income statement. And make sure you're including crosswalks from those supporting documents once again. One of the other pieces that they added is medical supplies and other that are included on this schedule can include direct care costs, but should not include direct care worker wages. So medical supplies and other can include direct care costs, but should not include any personnel wages or salaries. The key points on this schedule is schedule 4 must equal the schedule 3 program admin total. So if I go all the way back to the schedule 3, that's column 5. Your total in column 5 has to be equal to your total from schedule 4. And all schedule 4 expenses must be allocated on schedule 3 using acceptable allocation methodologies. So when you're allocating your expenses from schedule 4 over to schedule 3, you'll use one of the allocation methodologies that we go over in the future to make sure that this is allocated correctly. So it has to tie, and you got to use an approved allocation methodology. So here's what schedule 4 looks like for all services. I know at the top of the table says 4A, 4B. Used to be that the FI was different, but now they're all identical. 4A, 4B, 4C are the same. We don't have 10 or 11 columns anymore, which is great. We've got 2 columns. This is the simplification I was talking about. So we have the same lines that we had historically. And I know there was a comment. I may save questions for the end. Oh, good question. So this is a great question. If you are a provider of both LICSA and FI services, which also does NHTD and TBI services, would you fill out under non-reimbursable costs on schedule 3B and 3C, the NHTD, or only under 3B or 3C for these non-reimbursable costs? So I know I was going to wait till the end, but this is a really good question. So there is no specific instructions. If you are an entity that has both LICSA and FI, so you're filling out for the same agency, for the same entity, schedules B and C for the LICSA and FI, there is no parameters for where it should be included. I would put it all on one schedule. That could be 3B or 3C. I probably would say the LICSA because that's where, most of the services, are representative or similar units of service that we're looking at when we're comparing. So I would put everything on 3B But there is, you could break it out between 3B and 3C. I think that would make things a little bit more convoluted and complicated for your own reporting purposes. So if you think about it, you would be reporting your expenses for your LICSA on B, your FI on C, and then putting all of your non-reimbursable services on one schedule. So I would recommend putting them all on one schedule. And, just my personal, thought process is I would go schedule 3B for those services. So it's a great cost. There is no specific instructions. I think allocating them both between 3B and 3C would be a little bit convoluted because we want to make sure we're representing the full cost of those services. The only thing that you're going to have to look at is, and those services for those, you would want to look at also who's providing those services for your agency. Is it the same staff that's providing your LICSA services? If so, then I would definitely put it on B. If there's some shared staff that's doing NHTD and TBI across B and C, then maybe you would put it on both schedules, but you want to look at who's providing the services. And since FI staffing is obviously quite a bit different than our LICSA staffing, and those NHTD services and TBI services are usually provided by aides and skilled nursing, I would definitely most likely put most of those expenses, if not all of them, on B. That would be my recommendation if you're one of those entities that's doing both LICSA and FI. So great question, but that's my recommendation. But it's for your entity who's providing the services. So if it's the same staff that's providing your LICSA services, you want to include it on B, so it's easy for you to dedicate the salaries and the other expenses that are associated with those non-reimbursable programs for the NHTD and TBI services. All right, so going back to Schedule 4, program admin, and then direct care non-personnel. So only 2 columns, no longer the 10 columns, no more staff training, no more transportation, no more contracted services. So your program admin and your first column includes, all your overhead, everything you would think, your rents, your depreciation, your utilities, your office supplies, all of your A&G expenses in there. Then column 2 is direct care non-personnel costs. So once again, they want to make sure this is specific. Do not put any of your direct care wages. Do not put any of your direct care individuals on this schedule. That is only available to open. You'll see I grayed out the cells here. Only available to enter data for medical supplies and other. So if you had any medical supplies, say you maybe had some drugs or some DME that was patient related, durable medical equipment for DME, maybe patient transportation, if there's an ambulance, anything that you're paying for that might be patient specific, that might fall into other, that's what you would put into direct care non-personnel. Everything else is going to fall into program admin. So the next question is, if we're a LICSA who has a contract with a CHA, shall we report the costs associated with the CHA as non-allowable? So if you're a LICSA and you're contracting your employees to the CHA to provide home health aid services to that CHA, then yes, you're subcontracting your employees. That's what we reported on the subcontracted line of the LICSA cost report as non-reimbursable services, because you're not reimbursed for the expenses that you're incurring for the wages of the staff that you're contracting out. Another good question. All right, so Schedule 4, we removed a lot of columns, as I mentioned. We went down to 2 columns. So we removed program aid, RN supervision and assessment, staff training, transportation, contracted services, and other. So very straightforward. They did this to streamline the process of reporting on Schedule 4 per request and recommendations from providers after they completed the cost report. In addition, criminal background check and fingerprinting, as well as employee physicals, uniforms and immunizations, are only open in program admin. So no longer can they be reported in any other columns. It's strictly program admin. And as I mentioned, we want to make sure that direct care non-personnel expenses added to include direct expenses such as medical supplies, because as I mentioned, there's others, drugs, DME, etc., patient transportation, labs and diagnostics, x-rays and imaging, anything that you may incur that's a cost of patient care would go into that direct care non-personnel line. Or excuse me, column. So Schedule 4, how do we go from Schedule 4 to Schedule 3? And I know this is a simplified version, but we wanted to make sure that it was a straightforward. So we've got Alexa, and they're serving Albany, right? And so on the right-hand side, we got our program administration. Excuse me, that should say column 1 for that. But we got our expenses totaling $4,000 in admin. You know, very simple, very small, very easy values to see. I know yours are going to be a bit more complicated, but say that, you know, you're allocating these expenses. This is what ends up in the Albany County for expenses. So what we do is we take the expenses in the program admin, all 4,000 for Albany, and they have to flow to Schedule 3B for Albany in the same total. So that $4,000 at the bottom line ties. And we're taking that $4,000 and we're allocating it based on the level of care. So we're allocating it to PC level 1, PC level 2, and nursing assessment in this case, based on the percentage of units of service for those services in that county. So the totals tie, and then we're allocating. So in this case, 50% of the units of service were for Albany were PC level 1. Then let me think, what's 75% of 50%? Quick math in my head. So it's 37.5%, sorry about that, of the expense of the units of service were PC level 2. So that's where the 1,500 comes from. And the last 12.5% are nursing assessment. So that's where the 500 comes from. So we're taking that total of 4,000, putting 50% on PC level 1, because that represents 50% of the services, 1,500 on PC level 2, because it represents 37.5% of the services, and $500 on nursing assessment, because it represents 12.5% of the services, of the units of services provided within Albany County. So that's how you go from each of your Schedule 4s to each of your Schedule 3s to make sure that you tie across each county. So next up, we're going to talk about the financial reconciliation tab. We're going to talk about allocation methodologies and crosswalks and everything a bit later. But the financial reconciliation tab was added last year to help agencies make sure they're tying to their financial statements. The tab is not accessible until after you complete all of the cost report schedules, and you can utilize this to tie back to your total entity costs on 3A, 3B, and 3C. So you'll enter your total expenses and the bad debt listed on your financial statements, and then the tool will automatically calculate if there's any variance between your financial statements that you reported, as well as what's on Schedule 3. So they're building in a bunch of self-checks. This is the one they added last year. They have a couple other that they're adding this year on the statistical when we get to Schedule 5 that you'll see as well. So I apologize, this should say Schedule 5. So now we're moving on to Schedule 5. So this is dedicated schedules. Once again, there's 5A, 5B, and 5C for each of the programs. And it's geared towards agencies, including patient counts and units of service, whether they may be visits or hours, by service type and by payer source. When you're looking at the payer sources, we're looking at Medicaid, Medicare, private pay, other, and dually eligible patients. So when we break down Medicaid, we need to break it down even further. So we've got our traditional Medicaid fee-for-service. That's defined as when New York State is providing you direct reimbursement for the services being provided. And then we've got our Medicaid managed care. And this is the reimbursement being provided through contracts that providers have with MLTCs or MCOs. So some examples of those MLTCs or MCOs include Fidelis, United Healthcare, Health First, Age Well, Aetna Better Health, etc. So when you're breaking this down, it's important that you're identifying this. And this is one of the key schedules, your statistical information to crosswalk. And we'll talk about that when we get to the crosswalk portion. So this is what the headers on Schedule 5 look like. So you've got your Medicaid, as I mentioned, broken down between your fee-for-service, that's your traditional Medicaid paid to you by New York State. Then you've got your managed care, and that comes from the contracts you have with those MCOs and MLTCs. And then we have a subtotal that will automatically calculate within the cost report of the Medicaid fee-for-service plus the managed care. And you need to provide patients and either visits / days or hours, depending on what service you're being provided, what's the unit of service, what's the increment of reimbursement. So when you question, what's the unit of service, what increment are you being reimbursed for? If it's 15 minutes or 60 minutes or whatever it is, that would be hours. If it's per visit, it would be visits. Next up, we have our dually eligible patients, and then we have our Medicare patients. And then we have private pay and other. And then we have a grand total at the end that will be total unique patients. Now, total unique patients will not duplicate your dually eligibles. Your dually eligibles will be reported once, not separately between the multiple payers that they may be eligible for. So they changed Schedule 5 as well because they wanted it to mirror Schedule 3. So they want the units of service and the cost to be representative. So if you have units of service in any of the non-reimbursable services or personal care lines for the CHA, for example, you need to have cost on Schedule 3. So wherever you have units of service on Schedule 5 and in your grand total, you need to have costs reflected there on Schedule 3. Same thing for the LICSA. They detailed it the same way they did on Schedule 3. They wanted all of these to mirror Schedule 3. So you got your PC services, your nursing services, your shared aid services, then you've got your subcontractor, your HHA, and your non-reimbursable. So the individual that asked, if I'm subcontracting out my LICSA employees to provide services to a CHA, you not only need to track the expenses, you also need to provide the units of service for the subcontracted staff members. So how many visits and or how many hours of service are they providing? And that's what will go on Schedule 5 here. And then lastly, your FI, same thing, mirrors exactly like Schedule 3 with your individual and your multiples with the different levels of care. And then your other non-reimbursable services, if you have any other non-reimbursable services under the FI. That's a duplicate slide, so I apologize for that. So the rows are now separated into those reimbursable and non-reimbursable service sections. The subtotal underneath here represents your total for your reimbursable services, and your grand total is the sum of all reimbursable and non-reimbursable services. Those will be automatically calculated on the cost report. And like I said, they want to maintain consistency with the cost on Schedule 3. So once again, now it perfectly aligns. You've got units of service on 5, which is where I always start when preparing the cost report. I always start with Schedule 5 before I do anything else. Then I move over to Schedules 3 and 4. So if you have units of service on Schedule 5, you need to have representative cost on Schedule 3 in those same lines. So column is added at the very end. So there's 2 columns added to the very end of Schedule 5 as well. And these are some of those self-checks that I talked about. So column, I don't know what column it is, so I apologize off the top of my head. I'm not as familiar with the new lines, but or columns, something like in the 20s. But there's a total entity cost column, and that will flow directly from Schedule 3. So it's going to auto-populate with whatever you put on Schedule 3. The total cost is going to flow over to Schedule 5. And then there's a calculated column right after that total entity cost column that's going to show the total entity cost per unit. So it's going to take the total entity cost from Schedule 3 and divide it by your units of service on Schedule 5 total to give you a total entity cost per unit. This is a self-check, so you can validate to be helpful in determining if the data reporting is reasonable before you submit. So you can look and see, okay, I'm providing other non-reimbursable services, NHT and TBI services under my LICSA, for example, under the same entity, same agency. Obviously, they're not under that program, but the same staff members are being utilized. What you can then look at is see, okay, does my personal care aid, level 1, level 2, hard to serve, et cetera, align with expectation in terms of per unit cost, as well as does my non-reimbursable services align? And if there's inconsistencies or you think it's your self-check of being, okay, maybe we misreported either some units of service or some cost on this. So it gives you that check to be able to look at your own entity's performance and see, okay, am I reporting this correctly? Is it in line with expectation? So the question is, please go over the 5A1, 5A2. I entered fee for service on 5A1 and managed care, MA, episodic, commercial, PPS on 5A2. I believe 5A1 and 5A2 are your pediatric, if I remember correctly. I do not have any agencies personally that are using schedule for the pediatric services. So I have to look into it. So Roberta, if you're interested, my contact information will be at the end. So it's a very specific question, and I've only got 18 minutes and quite a bit to get through, but if that's a very specific question, so you can reach out and we can have that discussion separately offline. All right. So, for Schedule 5, I recommend this should be a report that comes directly from a third-party vendor or your EMR. And specifically, we always request and recommend this should come from an EMR generated report, whether you're on, Sandata, Home Health Exchange, or any of the other, Home Care Home Base, any of the other EMRs that are out there. This should come from there, but it's really important to crosswalk. So when I'm working with providers, this is what I, normally do is I get on the phone with them. I take my best stab at identifying and classifying each thing, but I go through them line by line and make sure, okay, my expenses or my payers are mapped to each bucket correctly. So I'm identifying and classifying what's Medicaid fee-for-service versus what's Medicaid managed care, what's Medicare, what's private pay, what's commercial, etc. Then I'm looking at my different service types and making sure I'm classifying those correctly. What goes into PC level 1, what belongs in PC level 2, because it's not always clear on those reports. And then what's the unit of service for each of those? Am I looking at hours? Are we billing per 15 minutes? Are we billing per hour? Or are we billing per visit on those? So really going through and crosswalking from those supporting documentation. For those dually eligible patients, this is the definition that comes directly from the instructions. So Medicaid and Medicare columns, these figures should not be unique. An individual should be counted multiple times. For example, the patient's visits, days, and hours figures for a dual eligible Medicaid and Medicare individual should be counted in both the Medicaid and Medicare columns, and they'll only be counted once towards your total. So those dually eligible patients should be reported in both Medicaid and Medicare, as well as uniquely in that dually eligible statistical column if you've got dually eligible patients. So those are the major updates to those schedules. They really focused on schedules 3, 4, and 5 for the updates this year when they were going through each of the going through and making these updates. Some of the other updates that they did make were on the reporting hierarchy. Now, CHAS can list all the counties where services are provided. So previously, that was not something that could be done on the CHA home care cost report, but now you can list all the counties where you're providing services. It is not required for CHAS to detail out by county like it is for LICSAs and FIs. So LICSAs and FIs will still have to do allocations out for each counties. CHAS, you're still one consolidated schedule for the entire CHA, but you will list the counties where your services are provided on the reporting hierarchy. So that's on schedules 1 and 2 before you even get into the remaining schedules. Then there are several updates that they made to the general questionnaire. For example, they used to have 2 questions on allocation methodologies. Now they consolidated it into 1 question for what allocation methodologies did you use, and you check all that apply. They also changed the question. So if you're providing Medicaid managed care, so if you have contracts with those MCOs or MLTCs, you'll now need to identify those MCOs and MLTCs with which you are contracted. There will be a drop-down list that you can select from for all the MCOs and LTCs that you contract within New York State for those Medicaid managed care services. In addition, there's a question now on wage parity. So if you are subject to wage parity requirements, you will answer yes to that question. In addition to data reports, and they're asking, the question is specifically, are there any similar data reports provided to DOH that contain similar information? So they're looking to identify and capture, are there any other reports that you're providing to DOH that contain information similar to what's captured in the home care cost report? So they're looking to see what redundancies exist in this process. Another good thing, they haven't done anything with it yet, but they're at least capturing the information. In addition to that, to the questionnaire, they put a ton of information on their portal. I only get an hour today. There is a ton of information on the portal that you can get. They updated the instructions. So they updated the instructions to clarify in schedules 3, 4, and 5. They provided clarification on any reporting of negative values within the cost report. They put definitions of reimbursable and non-reimbursable services, which we went over here. They provide guidance, and I'm not going to go through it today because it's its own webinar, in my opinion, on calculation of the worker WR&R costs or R&R or RT&R expenses, where and how to report those WR&R or R&R, RT, and R costs on Schedule 3, and how to estimate your WR&R or your R&R, RT&R revenue to be reported on the cost report as well. So they provided guidance on this. It's great information. They have amazing schedules to help you with schedules 3, 4, and 5, whether you're Alexa, CHA, or FI, and detailed instructions. They've got source document recommendations for each schedule. I'll go over some of those in a minute. They've got non-reimbursable services listed for each entity type. So whether you're a CHA, Alexa, or an FI, clarifications on what might classified as non-reimbursable services. They got key takeaways from the 2021 and their lessons learned, which obviously led to a lot of the changes that you're seeing now. And the information on those self-checks and those automatic checks that exist within the portal. So, going to go quickly over some allocation methodologies before we touch base on the labor and compensation schedules. Like I said, I'm only going to touch base on those quickly, but allocation methodologies at the entity level. So you've got options here, and it depends on what you're allocating. So you can allocate based on total operating expenses, or you can allocate based on units of service, i.e. your visits, days, or hours. You could also allocate based on patient count. I don't recommend it. It's very rarely used, but different patients receive different amounts of services. So I would definitely lean towards units of service versus patient count. And all of your entities, across each, agency must provide those same services for these allocations to be utilized. So within an entity, you can use statistics, hours, total operating expenses, square feet for any thing that needs to be allocated based on square feet, your capital related, your rent, as well as time studies. Most frequently, when we're preparing cost reports at SimiTree, we're using one of two allocation methodologies: total operating expenses or total expenses, or units of service. Those are the primary ones. So what's an example of total operating expenses allocation? So when we're allocating benefits, if the benefits aren't detailed by employee type, which rarely they are, for example, workers' compensation is rarely broken out by employee type, then we would allocate employee benefits based on total salaries. So that's an example of total operating expenses. So taking your total benefits, including all your payroll taxes in there, and then allocating to your RNs and your personal care aides and other direct care staff members and your admin staff members based on total salaries for each of those departments. So that's an example of that one. When we're allocating by units of service, so your personal care services, right? Your personal care aides, that employee type might be providing multiple levels of care as well as some non-reimbursable services. I've got a client that I'm working with that their personal care aides provide PC level 1, PC level 2, NHTD, and TBI services. So we need to make sure we're allocating those personal care aid salaries to each of those lines based on the units of service. So that's an example of how we would utilize units of service to allocate. So if we had $100,000 in personal care aid salaries, 50% were for PC1, 25% were for PC2, and the other 25% were non-reimbursable, a combination of PC level 1, or excuse me, a combination of NHTD and TBI for those non-reimbursable. We would put $50,000 to PC1, $25,000 to PC2, and then $25,000 to non-reimbursable. So that's an example of the units of service allocation methodology. Those are the primary two that we're utilizing when we prepare cost report. So these are obviously those examples. So where can you use square feet? As I mentioned, those capital and occupancy related costs. So if you've got rent expenses and you've got specific portions of your building that are dedicated for your aides or for your direct care staff, maybe you're a child and you've got nurses and therapists, you could allocate the rent costs to each of those disciplines based on the square footage that they occupy in your facility. Now, most of this is home care, right? So when we're talking about home care, rarely do we have dedicated space in our buildings for our direct care staff. They're mostly in the field because they're in patients' home providing those visits. So that's why I said we don't typically see that utilized very often. We see it utilized more in hospice, for example, when we're doing hospice cost reports, but not as much on these home care cost reports or the home health cost reports that we do. In addition, if your agency has a time study, you could look at your salary related costs and be allocating based on time and, obviously pay wage adjusted for aid versus RN salaries. So if you have that information, you could do it based on hours worked, but you would have to make sure that you're clarifying and separating out your aid or RN salaries and expenses to do that. Or if they're combined, making sure you're weighting your RNs, which are paid at a higher rate than your aides. So like I said, both of those not used as often, more using hours of service and total operating expenses. So here we get into an example of a crosswalk. And I got 7 minutes left, so I apologize. I know there's a question there, but anything I don't get to today, if you put in the chat, I will definitely follow up on via email before the end of the week. So when you're looking at your trial balance mapping, you want to make sure that you're allocating and identifying your expenses. So I know I have non-allowable. I apologize. I should have adjusted to say non-reimbursable for this year. But you're seeing here, this is how we classified the expenses. So the salaries expenses, we have to allocate. We know we have to allocate. We have $500,000 in our salary bucket, but we got to allocate between PC level 1, RN, if we're a CHA, PT, et cetera, depending on what program you're in, you're going to have to allocate those total salaries, as well as your benefits, same thing. You're going to need to allocate your benefits based on the employee type that you're working with. Then we've identified, okay, marketing and advertising and meals, those are non-reimbursable services. So we need to make sure that those go into the non-reimbursable services column, as well as our income taxes, cash receipt, assessments tax. And then we have our bad debt, which we need to include on our revenue and not include as an expense. So you see down at the bottom. Then we've got our administration expenses. So we've got our utilities, our depreciation, our rent, our supplies in there. And then lastly, we have our staff training. And our staff training is a direct care expense that we're going to put into these. So this is how we start to categorize. So I recommend starting with what's direct care, what needs to be allocated, what's non-reimbursable, what's administrative. So what goes on Schedule 4 versus on Schedule 3 in the direct care columns on Schedule 3. And then what line or column does it belong into? And as we get into more detail, here's that $500,000 in salaries broken out. So we have $100,000 for RNs, $125,000 for LPNs, $175,000 for aides, and $100,000 is admin. So there's our breakdown of our salaries by discipline or department within our organization and the percentages. So then we got our $250,000 in benefits. We're going to allocate those based on the total operating expenses in each of those salaries. So we're going to put 20% of the 250 to RN, 25% of the 250 to LPN, and so on and so forth for aides and administrative. So this is an example of, okay, now we've got that $500,000 in salary expense broken down, and we can see, okay, RN is going to go on Schedule 3, and depending on whether Alexa or CHA, they're going to go to a specific line in the program aid direct care column in the cost report. Your LPN, same thing. It's going to go on Schedule 3, and it's going to go for nursing services. Your aides, then, we have to look at, okay, we might have to take that aides cost, if we're talking about Alexa, and break it out between PC level 1 and PC level 2, or PC level 1, PC level 2, PC level 2 hard to serve, and live-in, depending on what levels of care and services we're providing. So those aides may need to be broken down even further. And then our administrative salaries, those would go on Schedule 4 and flow over to Schedule 3. And then our benefits would be included with our salaries. So our RN on Schedule 3 is going to include $100,000 in salaries plus $50,000 in benefits. These are going to be broken out on the labor and compensation schedules, but on Schedule 3, they're combined. So how do we then allocate between the units of service? So here's an agency servicing 3 counties in New York. Their services broken down between PC level 1, PC level 2, and live-in. And you can see the volume of services. Obviously, County 1's their biggest, County 2's their second, County 3's their smallest. Looks like they're doing primarily PC level 2 services, a little bit less of PC level 1 and a moderate amount in between the two of live-in services. So then down below, we got our percentages for each county and each level of service. So what we would do is we would take the aides expense for this agency, the 175,000 plus the 87,500 in benefits, and we would allocate it. If you do not have the detail or the ability to allocate your own wages by county to each county, and you would put 12.6% in County 1 PC level 1, 22.7% in PC level 2, 9.4% in live-in in County 1, and take those values across the board. Now, some agencies have this information already broken out by county, which is great. That's even better. But then you would need to break out within each county for those aides that are servicing that county. You would have, your percentage of PC level 1, PC level 2, and live-in each county. And this total down here on the bottom would be 100%. So whatever portion of your 175,000 in aides, say it was, 100,000 of those in county number 1, then you would have, your percentage allocated for County 1 here, or for PC level 1 here, PC level 2 here, and live-in services. So I'll quickly touch on, I know there's more questions. Like I said, I'm going to have to get back to them by the end of the week. I know I answered some questions as we went. The labor and compensation schedules. You can use different supporting documents for these schedules. So these should come from your payroll reports. And so they are required to include both full-time and contract labor rates, so wages for both of those employees, as well as hours for those employees by type. And my recommendation on these schedules is always break out as much detail as you can from your payroll reports when you're doing this. So when you're looking at base wage out for hours worked, in-service wages, travel wages, overtime wages, not everybody has weekend and mutual differential dollars broken out, or holiday worked wages or other wages. So break out in as much detail as you can and identify and crosswalk on these schedules. And so when you're looking at schedules 8 and 9, they are FTE, salaries, and benefits. And then schedules 11 and 12 break out the salaries on schedule 11 and the total hours on schedule 12 to calculate an average hourly rate. So here's 8 and 9 with the headers, with the different categories: supervisors, nurses, aides, clinical therapy, other, and total. And then your labor utilization for your hours by type, and then it will calculate and lead to your average compensation. As I mentioned, I wasn't going to spend too much time on these today because I know I only got an hour, but I did want to get to this. So this is the suggested source documents for the schedules. And so you can see, and you'll receive these slides so you can have all of them, but it shows recommended source documents for schedules 3, 4, 5, etc., all the way down. Now, some of these may be redundant. You may not have mileage logs. Your mileage reimbursement may be included in your payroll register, your payroll reports. So don't use this as, the Bible of like, you have to follow this. But it gives some recommendation for where the information may come from within your organization. Your payroll register may be able to be used for 8, 9, 10, 11, 12, 14, and 15. So you may be able to use that one report to populate all of those schedules. Excuse me, not 50 or 15 and 16, not 14. Just want to make sure I didn't misstate that. But your important schedules, what I always ask for from a client is your general ledger, your trial balance, your income statement and your balance sheet, so your audited financial statements, and then some kind of payroll report at least that I can work with, and then some kind of EMR statistical report that I can work with to at least get started on these, and then trying to see what other reports we can use to fill in the gaps. So lastly, on the audit process, I've touched on this a little bit. Those work papers that I showed as an example are absolutely key. And you want to make sure you're crosswalking to those work papers and you're following, it's very clear. You have your source documents, link to a crosswalk, link to the schedule. And this you can have all in one file, gets a little convoluted and complicated, or you can have each individual schedule with a source document, allocation methodologies, crosswalk, and then a populated schedule. They want to see these reports in Excel when they're going through the audit process so they can link and see how you got from your source data to what was reported on the cost report. In addition to that, we recommend writing a policies and procedures that detail this process. Where did the source document come from? what allocation methodologies did you use? Where is your crosswalk? And then, have that all be supported, that policies and procedures in the work papers that you're submitting. So I know I'm out of time. I apologize. These are due August, it says August 3rd, August 30th, forgot to put the 0 in there. I apologize. But August 30th, just a reminder that these are due August 30th. And my contact information is on the screen. And Pat, I know I'm out of time, so I'll let you jump in.
Actually, we started 2 minutes late and you ended it right on the dot. So you did an amazing job. I don't know how you got through everything, but you did, and it was fantastic. Very, very helpful for, I would hope everyone. It was very helpful for me as well. And I'm glad DOH has made some changes that actually work and simplify things. So that's great. I think what we'll do is we don't have time for Q&As, but we'll share with you the participation list that has people's emails. So you did get a handful of questions, like 3 or 4, but you'll have their contact information on how to get a hold of them. And if anything else you need, feel free to contact me tomorrow or whenever. After I know you're traveling, so hopefully you don't have to give me a call. But I thought it was terrific and really appreciate you conducting the session for us.
Of course. Thank you, Pat. And I want to thank everybody from New York State. I know these things are challenging. I know they're complicated. But partner with vendors and resources to help you out. Talk to your EMRs. They can help you and identify what reports you need to populate these. And there are other resources, out there that you can reach out to for help. And KPMG and DOH, they're listening to us. They're taking our feedback and they are willing to provide help. And the resources they've already provided are incredible. I was going through everything this morning with my team and highly recommend going through all the detailed resources, instructions they have. And then anything they don't, ask them questions. And they, may not get back to you immediately, but inside of a week, they're usually responding to all your questions. So I want to thank you, Pat, and, everybody from HCA, as well as, everybody that attended.
Yeah. Okay. Sounds good, Mike. Great seeing you. And thanks everyone for joining us. We'll be in touch here at the association. Take care.
Thank you.